So, may I have your attention, please? Today we are finishing our pathology, the study of the pathology cases of the endocrine system. And this case has to do with a rather acute problem involving both adrenal glands. So, there is a young woman who presents with pharyngitis and severe headache. She develops hypotension. How can this be related to adrenal gland insufficiency? How could low blood pressure be related to a damage in the adrenal glands? Which hormone might be involved in this? If it is aldosterone, probably. Yes, that's right. I think so. And she has palpable purpura within 12 hours. This is some sort of hemorrhagic skin rash. It's purpura. Schistocytes are present on her peripheral blood smear. Her platelet levels are low. This has to do with the hemorrhagic rash, purpura. And her coagulation parameters are all prolonged. So this is a systemic disorder of blood circulation, and it affects multiple organs, including the adrenal glands. So, despite the prompt administration of antibiotics and pressure support, she dies, and this is the appearance of her adrenals at autopsy, and you see how dark red they are. This is probably related to hemorrhoids. However, it is not only hemorrhoids, it is necrosis as well. So this is hemorrhagic necrosis occurring abruptly on both adrenals, and this, of course, causes an acute hormonal insufficiency. So this is the diagnosis, and we have, this is known as Waterhouse-Friderichsen syndrome. And we have acute adrenal insufficiency, and this is in the context of disseminated intravascular coagulopathy. This justifies the rash we saw in the skin, the purpura, and the prolongation of all coagulation parameters. So this could start due to the infectious cause here. She had pharyngitis, and most cases are related to meningococcus, and it causes all this severe damage. And we have a hypotension that is intractable. There are other infectious agents involved. However, most cases are related to Neisseria meningitidis. Now, what problem does this patient have here in her neck? If you see this, and this whole mass follows the swallowing movement, what could this be? This mass? It could be an hyperplastic thyroid, a goiter, all right? So, if, of course, we must ask from the patient's history, how long did it take for such a big goiter to develop? Because if the history is too short, this could possibly be a very aggressive type of cancer of thyroid, which grows very quickly. However, if she tells us that it happened, all this increase in the size of thyroid has to do with years or months, of course, the chronic history is not so consistent with malignancy. So we have a goiter, and have a look at the patient's hormones. TSH is normal, and T4 is normal as well, because as we discussed in our laboratory exercise, the thyroid hyperplasia is done so that the thyroid hormones remain normal. So most patients with a goiter have normal thyroid hormones, like the present patient. So, what can cause this? There is a form of endemic goiter in very, very high in the mountains when you don't have salt with iodine. That used to be a cause. It's no longer a serious one. However, if the patient is taking drugs which interfere with the taking of iodine and the whole process, so that the biosynthesis of thyroid hormone is okay, in this case, these are potential factors who can justify this clinical image. And very rarely, if you eat too much of some foods like some cauliflowers, we'll see, it could happen as well. So if that could happen in a child, then there would be a severe problem, because the child would be mentally retarded due to insufficient production of thyroid hormones. So this is a non-toxic goiter, which most commonly is multinodular. If the goiter is diffuse, then we must think of hyperthyroidism, because this is what happens with Graves' disease, hyperthyroidism. This is not the case here. The woman has normal thyroid hormone levels in her blood, so the goiter most probably is multinodular. That means that different parts of the gland respond in a different way to TSH stimulation. That's why some parts of the gland become enlarged and have a round contour, thus they are called nodules. These are nodules, and you can see that microscopically. You see the gland and it's not diffusely enlarged, that means retaining its shape, but it has some balls. These are nodules. So this is probably a multinodular goiter, which in some cases, it could include an autonomously functioning nodule, hyperproducing hormones, and this would be a hot nodule in the scintigraph. And this could be a sort of toxic goiter without being Graves' disease, because as I pointed out, Graves' disease is a diffuse enlargement of the gland. Yes?
What does diffuse mean?
All the gland homogeneously increases in size. There are not some areas protruding like balls. The whole gland homogeneously increases in size. This is a diffuse enlargement consistent with Graves' disease. Okay? And of course, the signs of hyperthyroidism. So, what problem does this goiter cause in this CT? What's the problem here? And the patient has problems, and there's some sort of wheezing that can be detected. Why? Because the goiter, and you see the nodules? You see that this is a multinodular goiter. Have a look here. These are the nodules. You see? Round structures. So the size of the gland has increased so much that it displaces, which is this anatomic structure being displaced by the enlarged, the trachea, yes, the trachea. So, and also the esophagus is compressed, and we have these consequences of a nodular goiter, which has reached quite a big size. So this is an indication for surgery. And from the diet, there are some vegetables. You see Brussels sprouts, cabbage, cauliflower. When overconsumed, not in normal quantities, when overconsumed, might be a cause of these enlargements. So could this become malignant? Not possible, because when we have many nodules within the thyroid parenchyma, the possibility of malignancy is very low. When the possibility of malignancy is high, when there is a single nodule, not cystic, a solid one, and it does not uptake the iodine in the scintigraph, and thus it is termed as a cold nodule. A single, solid, cold nodule might raise suspicion of malignancy. So, what's the method to check? We do not remove surgically the lesion. What is the method we use in such a lesion to see if it is benign or malignant? Which method having to do with the microscope is used? Which method? To check a nodule of the thyroid. Which method is this? Having to do with pathology and the microscope. You go to the radiologist, he has an ultrasound, and what do you do what? Yes?
Fine needle aspirate. The
fine needle aspiration. You have the ultrasound, you see where the nodule is. Of course, you have seen the scintigraph first and know which lobe it is and which in the upper part, lower part. And you put a needle, take cells from all places of the cold nodules and make a cytologic smear. This is fine needle aspiration. If you have signs of malignancy, then of course thyroidectomy is necessary. Okay? So that was a nodular goiter, multinodular goiter, quite asymmetric enlargement with multiple nodules. And if, remember that if this development is quick, this could be related to an aggressive type of carcinoma. However, this is not the case most times. In most times, it's a gradual enlargement occurring during years to reach this size. Here, we have a woman with a 6-month history of fatigue, anorexia, weight loss, skin hyperpigmentation, and diarrhea, and she develops hypotension. That's similar to the first case we had. You remember the hemorrhagic necrosis of both adrenals? It's something similar here. A hypotension after a minor upper respiratory tract infection. So, look at how small both her adrenals are compared to the normal sized ones. And what do we have here? This must be a primary chronic adrenal insufficiency known as Addison disease, and which is most probably autoimmune. The nature of this disease is probably autoimmune. That means that T cells attack the cells of the same host. They think they are foreign, however they are not. They are cells of the same organism, however they are attacked. So, we do not have enough amounts of aldosterone. We do not have enough amounts of corticosteroids. If there are not enough corticosteroids, taking into account that cortisol is a diabetogenic hormone, if there is not enough cortisol, what will the glucose level in the blood be? What will the glucose level in the blood be? They will be low. That's why the patient has hypoglycemia. And if we do not have enough aldosterone secreted from the glomerular zone of the adrenal glands, because you see, all the adrenal parenchyma is shrinked. It shows some sort of destruction of an autoimmune inflammation. So if there is not enough aldosterone, what electrolytic imbalance will be noticed in her serum? Yes, please. What electrolytic imbalance? Tell me. Yes. There's no enough aldosterone. What does aldosterone do? It retains natrium and water, and it excretes Calcium, potassium.
So you have high sodium and low sodium, high potassium.
If there is not enough, aldosterone, will have hyponatremia, not enough hyponatremia, and hyperkalemia. The latter is quite dangerous for what? And should be properly treated. We should not leave the status of hyperkalemia, because which organ may be affected? Yes, the heart. The rate of the pulse of the heart, and perhaps a severe arrhythmia may develop, or even an arrest of the heart. So hyperkalemia must be treated properly. So you have some cases here, autoimmune mainly, but there are some inflammations which destroy the parenchyma of the adrenals, such as tuberculosis, immunodeficiency syndromes, and metastatic cancer. You should take that into account, because the adrenal gland is a common site of hematogenous metastatic spread from various cancers. For example, cancers of the breast, they metastasize to the adrenal glands. So they destroy the adrenal glands parenchyma, and there is not enough hormone. Lung cancer, again, can metastasize hematogenously to adrenal glands, and thus the stage of disease will be terminal. If we have hematogenous spread of a cancer involving the adrenal glands. Yes?
In Addison's disease, do you also have damage to the medulla, or only the...
No, I think only the cortex is mainly affected. We do not have problem in catecholamine secretion. That's what I think. You see here is another patient with some sort of autoimmune disorder, such as pernicious anemia. What does this mean? It means that there is an immune-mediated destruction of parietal cells in the body of the stomach, so there is not enough intrinsic factor production, so that B12 vitamin is absorbed in the intestine. So it has an autoimmune background, this patient. And what does she develop? Look what her adrenals look like. They are atrophic, as in the previous case. So, since the cortex is atrophic, there is not enough secretion of the respective hormones. Of course, we know the hormones, aldosterone from glomerular zone, sex steroids, mainly from the reticular zone, and glucocorticoids, mainly from the fascicular zone, but from all layers they can be. And there are the catecholamines deriving from the medulla. And we have the molecular base. An autoimmune regulator gene can be mutated, and this can cause a syndrome. And always remember that the most common mechanism of destroying the adrenal cortex is autoimmune. That means self-reactive T lymphocytes are responsible for the destruction of the adrenal cortex. Now, let's have a look here. It's a 26-year-old woman with epigastric pain and hematemesis. If we have hematemesis, that means that you have a blood in what you have from your upper gastrointestinal tract. What does this mean? What can cause bleeding in a mucosal surface? In the present context, in the mucosal surface of the upper gastrointestinal tract. What can cause bleeding? What can destroy a mucosa? Which processes have we learned in our courses of general pathology that may destroy a mucosal covering epithelium? Yes?
Maybe we have acid reflux from the stomach.
That's the cause, yes. And what will this be responsible for? What will the mucosa What will happen in the mucosa?
It will start changing. It will change from one type to another.
That's most common in the esophagus mucosa, not in the stomach.
No, no.
When we have such stressful and harmful stimuli targeting the gastric mucosa, what do they cause?
Ulcers.
Ulcers, yes. It's an erosion which, when left untreated, may cause an ulcer. This will be of inflammatory origin. However, when we see blood coming from the upper gastrointestinal tract, there is also another possibility. That's why the patient must have an endoscopy and see the area which bleeds. Is it from inflammation? Is it a benign ulcer? Or is it a malignant ulcer? Or is it cancer that erodes the gastric mucosa? However, in the present case, we had hematemesis. However, we did not have, we had some ulcers, the pathogenesis of which was outside the stomach and the duodenum. Let's see what happened. So we have multiple antral and duodenal bulb, the bulb of the duodenum, ulcers. And what does the CT show? Which organ is this? You see, it's behind. This is the stomach, this the pancreas, and here is a tumor. You see? So what can this tumor, because you know that the pancreas has two zones, the exocrine, which is responsible for digestion, and the endocrine. Which hormone may be related to the formation of multiple ulcers in the gastrointestinal, in the upper gastrointestinal tracts, probably causing hyperchloridria, probably. Which? It's not pepsin, the other one. Gastrin. Gastrin. So this tumor may probably produce quite a lot of gastrin, and this will have a harmful effect on the mucosa of the duodenum and the stomach. So, this is related to a neuroendocrine tumor, which can be of benign or malignant nature. We say it NET, neuroendocrine tumor. Yes?
But isn't the gastrin produced in the stomach?
No, it's not always produced in the stomach. It may have an ectopic source of production. In a sense, yes.
Thank you.
So we have a neuroendocrine tumor causing the Zollinger-Ellison syndrome. So these neuroendocrine tumors, they are not all benign, thus the term adenoma is not so specific. The correct term is neuroendocrine tumor because they can become locally invasive, or they can even metastasize, most commonly to the liver nearby. So we have an elevated serum gastrin level due to what the cells of this neuroendocrine tumor produce. And when we have other tumors, you see where such neuroendocrine tumors may develop: peripancreatic tissue, wall of the duodenum, ectopic pancreatic rests. And sometimes this can be in the context of a multiple endocrine neoplasia type syndrome of type 1, which includes pituitary adenomas, these islet cell neoplasms, and lesions of the parathyroid glands. Can you tell the difference between the normal pancreatic parenchyma and the tumor? Where do you recognize tissue which most probably corresponds to normal pancreatic parenchyma? On the upper part of the image or in the lower part of the image? You see normal pancreatic tissue. Normal pancreatic parenchyma consists of those cells, they form the acini, which is the exocrine part, and the endocrine part, which is composed by which structures? The Langerhans islands. So, can you see such in the lower part? Here is a Langerhans, you see, island, and normal parenchyma, and here is a neoplasm having a rather organoid motive of the neoplastic cell configuration. That means that such tumors, when are of low grade, not high grade neuroendocrine tumors, in high grade neuroendocrine tumors, the architecture is not organoid, is diffuse architecture, solid, I would say. But in these cases, when we have what was previously termed carcinoid, that means a neuroendocrine tumor, we see the neoplastic cells forming organoid structures, such as trabeculae, islands, some pseudoglandular structures, like the ones we see here in this neuroendocrine tumor, in this gastrinoma, all right? And we had, of course, a capsule. Here is the fibrous capsule. And what happened to this patient? Let me have a look. 1 year's history of syncopal episodes. So this might not be a gastrinoma. That's another patient here, not the previous one who had the ulcers on the upper gastrointestinal tract. What can be the cause here of the syncopal episodes? If you lose your senses, what's the first to check in the blood? The sugar, of course. So what hormone normally produced from the Langerhans islets is responsible for this syncoptic crisis? Insulin. So this is another neuroendocrine tumor secreting insulin. And how can you tell? You see, of course, that the plasma insulin is increased. There is one way of finding if there is a cause of increased insulin production in contrast to the one you take yourself. Because if you are diabetic patients, you have injections of insulin. What will you look so as to discriminate between these two causes of increased insulin in the blood? What you look is the plasma C peptide level, because in case that you took exogenous insulin, this peptide level would not be increased. Okay? So if you want to check if the insulin is from somewhere in the body, a region in the body, a mass in the body, you of course measure the hormone itself, but you also take into account the levels of plasma C peptide. What's the problem here in this thyroid scintigraph? What do you see? Is there a lesion having to do with the whole parenchyma of the gland, or is it one area of the gland that is problematic? And what is the configuration? What is the configuration of this area? What do you think that is wrong here? Can you show me? This area. Excellent. You had the round contour. So since it has a round contour, it can be described as a, no, the round, how we say it in the thyroid, if there is a round lesion? A nodule. So now that this nodule takes more iodine, that's why it's black, how would you describe it?
It's a hot nodule.
A hot nodule, yes. This is a hot nodule. Is it a single nodule? Yes, it appears to be a single nodule. The adjacent thyroid parenchyma is not of nodular consistency. So what can this be? This can be a neoplasm. This can be a neoplasm. It takes more, it's hot because it takes more iodine than the surrounding tissue. And in these cases, it is a follicular adenoma because it's a single nodule. The remaining thyroid has no other nodules. It's not a nodular hyperplasia, thus, and it is not likely to be a toxic multinodular goiter because there is only one nodule taking more iodine. And of course, what signal pathway might be the cause of this gain of function? It could be an activating somatic mutation in the TSH receptor, and this will drive the follicular cells to proliferate. It is of vital importance when we have a single nodule with a follicular architecture to rule out papillary carcinoma, because papillary carcinomas, not the classic type with the true papillae, papillary carcinomas can have follicular differentiation. However, how will we discriminate a papillary carcinoma with follicular differentiation from a follicular neoplasm? Either an adenoma or a carcinoma. How can you tell the difference between these two lesions, both of which have follicular pattern of architecture? No, raise your hand. Talk directly. Okay, it's good, but raise your hand first. Yes, you tell me. Yes.
By the nuclei in
the nuclear characteristics. No empty orphanani nuclei here. All right? So it could be an adenoma, which must have a rather thick capsule throughout the lesion, well circumscribed. It may cause some pressure to the adjacent thyroid parenchyma, which will thus look somehow atrophic due to the pressure the adenoma causes, and the adenoma within itself will be of different configuration of the follicles than the remaining neighboring thyroid parenchyma. Okay? And there will be no invasion of the capsule, no invasion of vessels, either within or outside the capsules, because these would be signs that it is not a follicular adenoma, but instead it would be a follicular carcinoma of the thyroid. Let's have a look. You see the follicles? They do not look normal in size. They are rather small, rather small. Let's see the hormones. TSH is okay. T4 is okay. So, this is a follicular adenoma, absence of nuclear features of papillary carcinoma. And if you see some cells, neoplastic cells, being quite pink with abundant cytoplasm, this could be consistent with Hirthle cell change or metaplasia, or oxyphilic cells. They would be like oncocytes. So is this a toxic? Is this a toxic follicular adenoma? No. Why not? Because the hormone thyroxine is normal. So it does not hyperfunction, it does not hypersecrete thyroxine hormone. And of course, look at the percentage. It raises suspicion if we have a cold nodule. However, all cold nodules are not necessarily cancer. Only 10% of such adenomas appear cold and will take many, many sections to examine under the microscope, because we have to examine the capsule. The capsule must be throughout the lesion so that it is a true follicular neoplasm, not an adenomatoid nodule, perhaps in the context of multinodular goiter. So we must take sections. And what is of crucial importance? If you see fiber tissue being entrapped by the follicles, always ask the clinician if a previous FNA biopsy has been performed, because this would not be invasion of the capsule, but it would be a reactive production of fibrous tissue in the area where the needle entered to take the sample. So, if you are suspicious of capsule invasion, always exclude prior treatments, okay? Of course, if you see emboli within vessels, either in the capsule or above the capsule, these are signs of malignancy. Then this is a follicular thyroid carcinoma. And the genes involved, you see RAS and this fusion gene here. What problem do we have here? There is some problem in the pituitary gland. This is a woman of 35 years old, 6 children, and develops amenorrhea, lethargy, cold intolerance, weakness, and diffuse skin pigmentation. How can amenorrhea be justified in this patient, taking into account what you see in the CT? What may be the cause of amenorrhea in this patient, taking into account what you see? Yes?
The hypophysis does not produce the
FSH, LH. This would be a probable cause. What hormonal problem could be related to the patient's cold intolerance? What problem? To the cold intolerance. This is a sign of hypothyroidism. So, what problem would be? This would not be a primary hypothyroidism because the problem is in the pituitary gland. So, which problem is? Which hormone? Thyroid stimulating hormone. Yes, TSH. So, what happened here? We have an empty cella syndrome with panhypopituitarism. See the low levels of TSH, the adrenal insufficiency due to low levels of ACTH, and the lack of FSH and LH. So, how can this occur? There might be a defect in the diaphragma cella, and this may cause an arachnoid herniation with compression and atrophy of the pituitary. That means a part of the brain is dislocated and causes increased pressure in this area, leading to the destruction of the anterior hypophysis. Yes, please.
She had this from when she was young, or?
No, because she has already had 6 children. So it's something quite acute. There is also a syndrome, I think we saw a case, Sheehan syndrome, when we have a postpartum pituitary necrosis. So all this happens when anterior pituitary part of a pituitary gland is destroyed. Now, what do we have here? This is a this is a very rare case. It's something we discussed with one of you in the previous lesson. But I want to ask you this. Have a look at the patient. Look at the sodium level, which is increased in the blood, and severely decreased, the same, the sodium level in the urine. And have a look at the plasma osmolarity. It is increased. And have a look at the urine osmolarity. It is decreased. So, which hormone is responsible for this electrolytic disbalance and these osmolarity disorders, either in the urine or in the blood? Which hormone is responsible, and is it due to its Hyperproduction or lack? Which do you think? Which hormone is responsible for the osmolarity? And, yes? ADH, yes. So this appears to be what we said, diabetes insipidus, all right? So what happened here? The problem is not in the hypophysis itself. The problem is in the pineal gland, And this tumor grows, and look that what it compresses the aqueduct of Sylvius, and we have an obstructive hydrocephalus. Thus, we have a dilation, an enlargement of the ventricles. And when we have compression here in the superior colliculi, and we ask the patient to look up, we see nystagmus. That means the eye goes like this when we have this test here, the upward gaze palsy. Why? Because there is compression in this area, in the superior colliculi. This mass, however, also compresses the pituitary, and this interferes with the posterior pituitary production of ADH. So we have hypernatremia resulting from a loss of free water reabsorption in the renal connective ducts. However, we do not have hyperkalemia due to the explanation that my colleague Dr. Milonas has written in the comments of our previous lesson. Because my friend asked me, okay, you had hypernatremia, why don't you have hyperkalemia? And how should I know? Do I know everything? I'm not a clinician, I'm a pathologist. So I asked my colleagues with whom I cooperate and make the clinical cases for the Greek program, and he wrote the answer. When I read it, I understood it. Now I've forgotten it. I've forgotten it now. Anyway, I'm not 20 years old. I am about 60. So this is probably related to this. Okay. When I read it, I understood it. Now I don't remember it. Don't remember it now. Anyway, as far as I remember what I say in the lesson, it's okay. All right. What's happened here? The last two cases are some rare cases of adrenal gland hyperplasia related to some enzymatic disorders. Let's have a look at the first. It's a 9-year-old girl. You see, there are some signs of puberty. And you see here that both adrenals are, the size of both adrenals is increased. Serum sodium and potassium are normal. Blood pressure is normal. What can this be? This increase in both adrenal size. This might be a congenital hyperplasia without salt wasting, because we see that serum sodium is normal. And we have a partial 21 hydroxylase deficiency. So a partial deficiency means that we have, in this case, low but rather adequate levels of mineralocorticoids and inadequate cortisol levels. So since there are inadequate cortisol levels, because the enzyme that is missing cannot produce, the cells cannot produce cortisol, this lack of cortisol production, what hormonal imbalance will it cause to the hypophysis? This will be a sign that a hormone from the pituitary gland will be increased, and it will act on the cortex, so trying to produce the cortisol, which is missing. So in this case, what will ACTH levels be? High. That's right. In the same mechanism justifies the increased adrenal production of sex steroids, thus the coarse pubic hair of this girl. We must pay attention if hyper-producing lesions of the glands cause man-like features to the patient. This can be a sign, if we deal with a tumor, not something like that here, this is a hyperplasia. If we have a tumor which causes masculinization features to the patient, it could be cancer. This could be a carcinoma arising from the adrenal cortex. Okay, but that's not, of course, the case here. The case here is hyperplasia, congenital adrenal hyperplasia. And here is another case. Look how big the adrenal gland has become. This is another case of congenital adrenal hyperplasia, and we have a lack of an enzyme activity, and we have a deficient production of aldosterone, so a lot of potassium is excreted, and we have salt wasting, and of course we have hypotension, and hyperkalemia. All these are findings related to the absence of aldosterone. Also, deficient cortisol production causing again an elevated ACTH level. And of course, ACTH targets the cortex of the adrenals, and we have overproduction of sex steroids. In this case, not having to do with cancer, as I previously said. In this case, no. It's a case of hyperplasia. And of course, you can give exogenous glycocorticoids to replace the cortisol that is missing. And if you give corticoids exogenously, you suppress ACTH. And ACTH comes to normal again. And when there is salt wasting forms of this congenital adrenal hyperplasia, you can also give mineral corticoids so that hyperkalemia is treated, is properly treated, and you protect the heart in this way. Okay? Those were all the cases. We've completed our case studies.